Hello, everybody, and welcome to our session today. It's great to have you here. We're talking about hardwiring health literacy into health information systems. So we'll be talking for the next hour, and I'm so glad that you're joining us today. So today's panel will be looking at 4 case studies that look at building health literacy approaches into digital health information systems. So a health information system is basically a system with technology for inputting, storing, and accessing health information. So all of the people that you'll hear from today work with Epic, which is one of the world's largest health software companies. And these are just a few examples of great work happening in health systems all over the world and health information systems all over the world. So during today's panel and our case studies, we're going to describe the health literacy strategy or initiative, discuss if there are non-digital considerations of health literacy in this work, and explore how patients can be involved in this work. And by the end of today's session, we hope that you will be able to name at least one feature in a health information system that can help to standardize a health literacy approach and consider multiple ways that patients can be involved in building a health information system or a patient portal. So without further ado, I'm excited to turn it over to our first speakers from the University Health Network, Alicia Gerbery, who's the Patient Partnerships Coordinator, and Lilac Chow, UHN Patient Partner, will be our first speakers to talk today about their experience with the health information system. Over to you, Alicia.
Thank you, Farah, and thanks to everyone for having me here today. So as Farah mentioned, my name is Alicia Gorberry, and I work in the Patient Partnerships Program at University Health Network, or UHN, which is in Toronto, Ontario. So today I'm going to share a bit about our Patient Partnerships Program and how our patient partners have been engaged in different organizational initiatives. So our formalized program at UHN works in partnerships with patients and caregivers who have had care experiences at any of our multiple sites. And here we see from Health Quality Ontario, and what we really do is our staff actively collaborate with patients and caregivers to really understand their needs, respond to them, and work together to improve quality, safety, and care around the organization and in the health system. So at UHN, our patient partners engage in different ways, and just to share a few examples, we have patient partners who sit on all of our quality and safety councils. They participate in leadership search committees, including our most recent search for our CEO and our surgeon-in-chief. They help to develop new programs such as our integrated care. And then during COVID, we had patient partners who helped to rapidly review patient-facing communication. So all of the communication, like the posters that were at entrances, or information that was on our website and information that appeared on our patient portal. And the patient partner role in all of these initiatives is really to bring their experiences, their expertise, and their patient perspectives to the table to really help us inform our decision-making, how our programs and services are designed, and our quality improvement initiatives. So we know all of the work that we do really trickles down to patients at the end of the day. So we're very happy to really build a culture where the patient voice is embedded into our organizational decision-making. Next slide, please. So right now, UHN is going through one of their largest projects to date, which is a huge clinical transformation. And organizationally, our transformation is called Synapse, and we're adopting this new health information system, which is Epic. So since the beginning of this project, vendors were bidding to be UHN's next system, and patient partners were part of the RFP process right from the start, and they really helped to inform the successful system, which is Epic. And since then, it's been about 2 years, or maybe 2.5 years. We've had more than 20 patient partners collaborating across this complex implementation structure of Epic, which is what you can see here in this graphic. So together with staff, our patient partners have really been working on governance committees, working groups, hiring panels. They've been sharing monthly presentations at dedicated town halls, really to ensure the system is reflective of the needs of our patients. So Epic has been implemented at several healthcare organizations across our province, but what we've heard about this one and what we're really proud of is that this is one of the first implementations where the patient voice has been so deeply embedded from the beginning and continuously throughout the project and in multiple ways. And it's also going to continue when Epic goes live in June as we capture patient-reported experience measures for quality improvement. The feedback that we've received so far from our Epic projects teams is that this is something they really want to continue as they move forward with other implementations, having the patient voice at the table to challenge us, prioritize what our patients need. It's been really invaluable in ensuring that Epic is implemented with our patient at the top of mind. I'm going to turn it over to one of our amazing patient partners, Lilac, now, who's going to share more about her experiences as a patient partner. Thank you.
Thank you, Alicia. Good afternoon, everybody. My name is Lilac, a UHN patient partner since 2015, and a transplant recipient of 7 years, and a My UHN patient portal user since its introduction. Like many patients, I went from being a person living a normal life to becoming a patient diagnosed with a life-altering disease and facing an uncertain future. Depending on strangers to tell me what was happening to my body, it became the norm. Suddenly symptomatic for a few months, I was diagnosed with a disease that would lead to eventual organ failure. It shook me to my core, and it forced me to learn not only how to navigate a healthcare system that I knew nothing about, but also to learn how to be an effective patient in order to survive when my body failed to do what it was supposed to. When my organs started to fail, the descent was fast and unforgiving, as my body also started to react. I counted 15-day surgeries, the one I remembered, within a 2-year period prior to my eventual transplant, a time that not long ago, where lab and test results were only released to a patient when consent forms were signed. Flash forward now to current day, patients like myself with complex underlying conditions, the current My UHN portal functionalities provides us, one, the ability to make better informed decisions on next steps, two, access to all health records, three, real-time results, four, appointment notifications, and most importantly, number five, validation of what the UHN Patient Declaration of Values stands for. See me, be kind to me, tell me, hear me, treat all of me, and partner with me. My health journey ironically introduced me to patient engagement when I was in my treatment chair back in 2013 with an invitation to participate in a joint project between UHN and St. Michael's Hospital that led to another opportunity to be considered to be part of a 23-member provincial panel to review the original QSIPA legislation, which stands for Quality of Care Information Protection Act, the following year. I was accepted. The ministry accepted the panel's recommendations, and the government introduced new QSIPA 2016, which included a number of changes from the original act that most importantly makes clear that patients and their families should have access to information, including all information contained within their medical records. To help facilitate the significance of what this decision means in Ontario, it is important to note that the recommendations for change was derived from the lived experiences of members from across the province, voices of patients and caregivers that represent approximately 320 Ontario hospitals, and this is data from 2020. Whereas being a part of a hospital council, the patient lens is to help improve quality, patient safety, patient health outcomes, and establishes a link between the hospital and the community at large. In preparing what I wanted to share today with all of you, I wanted to provide some background and context of how my journey and lived experience has shaped me as a patient partner and changed not only my perspectives, but my life. Today, I am one of the patient partners along with the patient engagement team involved, collaborating, engaging with the development and implementation of Synapse at UHN. I co-chair the Digital Patient Engagement Consultant Group alongside another patient partner and the senior manager for my UHN patient portal and digital. My fellow patient co-chair and myself also have a seat on the Digital Patient Experience Steering Committee, also known as the Advisory Council. It is here where we both discussed after a meeting the importance of patient access to historical data via the portal. We both agreed that access to both would be the ideal, but the historical clinical notes, which is longer than a few years, would be more beneficial. They represent the professional summary of our medical data, otherwise known as our journey. Our voices were received and heard. Working on Synapse as a UHN patient partner has been immensely rewarding. The invitation to patient partners to a seat at their table as an equal is not only forward thinking, but innovative. As an organization that I'm very proud isn't created equal. Hearing from my Northern Ontario patient counterparts who have shared publicly the disappointment that their seat at the table has been one of tokenism only. I am proud and honored to be a UHN patient partner where our voices are always heard. What is most encouraging is learning how beneficial Synapse's role will play in an authentic patient partnership with one's health journey and how safe it can potentially help a patient feel. How a patient can trust that Synapse changes will not only improve their experience to ensure that it is patient-centered, but it can help ensure that their health diagnosis is one that they won't be confused further about because they are more in control with it due to the available functionalities. Please don't stop involving our patient partner community in your discussions and especially at your table. As patients, we are the ones who experience direct contact with medical professionals whose goal is to keep us healthy and alive, but the strongest, most effective relationships are the ones who choose to work together like we are today. Thank you for your time. It is an honor to be here. Back over to Farah.
Lilac, thank you so much for sharing your words with us today and describing your experience. I think you've done such a great job of illustrating how, as a patient partner, you helped our organization see different areas, connect with community, and understand the importance of all of this work from your perspective. So thank you, Alicia and Lilac, for sharing the work that you've done. And it's so amazing to hear about the impact of patient partners in our work. And I have the honor of feeling it too. So thank you both very much. Now I have the pleasure of introducing our next set of speakers from Johns Hopkins. Melanie Brooks is a clinical systems analyst with Johns Hopkins Baby Medical Center, and Annette Piersky is a clinical informaticist with the Johns Hopkins Hospital. So over to you, Melanie, to describe your work over there.
Thank you, Farah. If you could go to the next slide. Oh, thank you. First of all, I just want to thank everyone for inviting us to present today. We're very excited to be here. We're excited to share our story at Johns Hopkins Health System, our way of hardwiring health literacy into the electronic medical record. Before I get started, though, I'd like to also acknowledge Tom Bauer, who's our Senior Director of Patient Education. He's the one that connected us with you, and he was out of town and unavailable today. So we're presenting in his absence, but he definitely led this throughout our health system. Next slide. Okay. In an effort to get insight from end users, we developed a survey using our subject matter experts to look at how staff find, access, and utilize health education materials with the patients. The survey was important for us to understand what was going well and what we needed to improve on in terms of health literacy and education within our health system. We wanted to hear the voice of the bedside clinician and determine ways to make patient education easier to use for our clinicians. We really wanted to put things at the fingertips so it was easy to give to the patients. So we did a survey back in 2017, and we had over 1,000 responses for the clinicians. All disciplines were involved. We included both inpatient and outpatient clinicians, and it was a system-wide survey. Next slide. Some findings from our survey were that staff were not comfortable with finding the education in languages other than English. We also identified some barriers to providing education, which was a lack of knowledge of how to access the education materials and resources that were available, inability to preview education content within the electronic medical record. It was a cumbersome process to go to the internet to then look at the materials and look at videos that were available. And then also limited education titles were built within our electronic medical record, and there was a burden with documentation. Next slide. So some interventions that we developed as a result of the survey was to embed a button in our EMR to allow for previewing of education materials and videos without leaving the electronic medical record. We updated our learning needs assessment, which to make it easier for staff to document. And then we also developed over 130 new teaching plans, getting the content from our subject matter experts. And this is all done in a harmonized approach across the health system. Next slide. So for embedding the education in the EMR, we built the disease-specific teaching plans. And within this, we attach patient handouts and videos to the teaching plan. So you have the easy handouts right on the teaching plan. So they were just a click away. That if you wanted to print them out, you could click them, print them. You could preview the videos. Also, these handouts and videos, we have patient tablets that the patients can view the videos in their hospital bed, and it does go to the patient portal. So when they go home, if they have the patient portal either on their phone or computer at home, they would be able to look at the handouts and the videos. We also added a button which has links to all of our handouts and videos, so staff can preview anything they want to before they give it to the patient. We've also, part of it, we educated staff on how to change the language. So with our handouts, it's just a button. We have Spanish for most handouts, and then we have many other languages, so you can see what languages, so you can print it in the patient's language. And for the video, it's the same thing. As the patient would open the video, there's a choice to choose the language that you want the video in. Next slide. The next thing that we did is we updated our learning needs assessment. We simplified this for clinicians. One of the main changes is we made it so we only document the primary learner. Previously, we had the option to also document co-learners. Staff would get lost in this trying to document everybody that was in the room, and our regulations are mainly that we have to document the primary learners. We just make a note in the chart that other people were present if they're not the primary learner. And then we also made it so we identified not the language that they speak, but the preferred language that they want, and then also the preferred method of learning in this learning needs assessment. We wanted to recognize the voice of the bedside clinician and really try to make this easier, because this was one thing that was causing the documentation burden originally. Next slide. So the development of 130 new teaching plans, it took a lot of time. We used the subject matter experts. So we would have calls with people from all the different hospitals getting together, trying to figure out what is important to teach. So we harmonized across the health system. And then we also attached handouts and videos to the teaching plan. So those can go directly to the patient when assigned electronically, and then you can also print out the handouts. We also built, in the teaching plan, we built a guide for new nurses. We wanted to make sure that if I'm a nurse and I have to educate this patient about the disease, and maybe I don't know it as well, this guide would take me through exactly what I need to be educating, so you don't miss any key points. Next slide, and I'm going to turn it over to Annette Persky, who is also with Johns Hopkins Health System. Thank you.
To be the one on that. Sorry about that. So thank you, Melanie. So after doing all of this work, the enterprise-wide patient education committee, we had a retreat, and what we heard was, well, we did a lot of work. We worked really hard, but nobody at the bedside really knew about it. The nurses working on the floor, the clinicians, nobody knew about it. So therefore, we developed an enterprise-wide patient education blitz. And the blitz included the use of paper, using health education literacy on paper and handouts, as well as electronic education methodologies. Next slide. Here's a picture of our patient education committee members. I hope it shows that they're really excited. So here the pictures are showing where we're planning for and actually doing the blitz and actually making rounds on the clinical unit. So we just wanted to let you guys know that, and notice that we have the top hats there and the balloons because we did putting on the blitz, but that's kind of a one-off for putting on the Ritz. So that's where all that comes from. Next slide. So our Blitz consisted of the following objectives and strategies. We wanted to educate both inpatient and ambulatory multidisciplinary staff. So this was definitely not just a nursing endeavor. We also utilized the health systems approach. We rounded on the inpatient and outpatient units. And when we went up on the units, we actually carried with us 2 or 3 focused topics that we wanted to touch base with the staff on that unit about. That could be a net new topic, something that we just recently did, or just reinforcing tools and tips that or tricks that were already there. And then we also posted short videos on our internet site to help with that kind of education if we were unable to reach certain staff when we went rounding up on the unit. Let's see, and before I transition to the next slide, after this Blitz, we went ahead and put out another survey, just like we did in 2017. So we put out another survey in 2019 because we wanted to look at that data to see if any of the interventions that Melanie had mentioned or the Blitz, we wanted to see if that actually made an improvement. So the next slide, we're going to talk about the improvements that we saw. Okay, so this slide is looking at from 2017 to 2019, and this slide shows the increase in usage of patient education materials, both in viewing and for printing out across from 17 to 2019. So you can see it's a 213% increase in the viewing and the printing of patient education materials. Next slide. And this slide actually shows similar data, but this is talking about the increase in usage of video viewing. So this is only for the patient. This isn't the nurse viewing the patient education videos. But you can see there's a 193% increase of video utilization from 2017 to 2019. Next slide. So what's next for us at Johns Hopkins across our enterprise? We're basically mirroring the improvement process cycle. You know, you plan, you do, you evaluate, and then you move on. So that's kind of how we do our process here. Also want to mention, if anyone does need to know, we had 2 years of COVID, so it was kind of quiet on building new things in our electronic medical record because we had higher priorities as everyone did. But during that time, that 2 years that we had the COVID, we do have several health system committees that provide interdisciplinary feedback back to our patient ed committees and leadership to let us know what things we need to work on to improve. So we did have that feedback loop going despite the COVID. And so with all that being said, we are targeting a new Blitz for the fall of 2020. And that ends our presentation. I'll turn it back over to Farah.
Thank you so much, Melanie and Annette, for outlining how you've approached patient education in your health information system at Johns Hopkins and how you've really had to reinforce it in order to ensure that it continues being used. I can see your future ahead of us too at UHN. So thank you so much for sharing with us today. I'm very pleased to introduce you everyone to our next speaker. Bhumi Kambolja is with Wisconsin Health Literacy, and she's going to tell us about Wisconsin Health Literacy's work today with EPIC. So over to you, Bhumi.
Thanks, Farah, and thanks for having me. I'm going to be talking about an EPIC systems feature that converts traditional medication directions like twice daily or every 12 hours to those that use morning, noon, evening, and bedtime timings, which is part of Wisconsin Health Literacy's medication label initiative. I'll provide an overview of why we're working on this and why this feature was created. And funding for this project is provided by the Advancing a Healthier Wisconsin Endowment of the Medical College of Wisconsin. Next slide. So Wisconsin Health Literacy is a division of Wisconsin Literacy, which is a nonprofit organization based in Madison, Wisconsin, that supports 70 literacy agencies across the state. In the Health Literacy division, we develop community programs to help both specific populations and the general public prevent and manage health issues. We also work with healthcare organizations to improve how health information is communicated. And we have a number of programs and services to do this, and the Medication Label Initiative is one of them. Next slide, please. The goal of the Medication Label Initiative is to make information on medication labels easier for all patients to find and use. So it's essentially changing the label you see on the left here to one that looks more like the one on the right, because medication labels are the most accessible resource that patients have to learn key information on how and when to take their medication. So some of these changes include putting the most important information for patients first, removing clutter, and standardizing the format of directions and making them clear and explicit. Next slide, please. So this initiative has been done in multiple phases, each one building from the previous, and you can see an overview of the phases here. Phases 1 to 3 focused on making changes to labels in the pharmacy. However, pharmacists are limited in how much they can change the wording of medication directions from what's written on the prescription due to legal and liability issues. So currently, we're on phase 4 of the project, which is focused on improving clear and explicit directions by prescribers. And this includes what's called the Universal Medication Schedule, which uses morning, noon, evening, and bedtime timings. Next slide, please. So in phase 1, we learned what some of the barriers and facilitators were to changing labels. And it was important to establish partnerships with different stakeholders to work through these barriers and champion the initiative. So these partnerships included partnerships with community members to have the patient voice drive this initiative, physicians, professors, pharmacists, and health IT professionals. And there are a number of ways for stakeholders to engage in this project. And one of them is to be part of an advisory group. For the project advisory council, we had and currently have software developers from Epic on that council. And we also had the patient advisory group consisted of community members who shared their experiences with taking medication or helping somebody else with their medication. Next slide, please. Wisconsin Health Literacy also surveyed community members. There were 798 responses, and 93% found labels confusing to read or understand. And you can see some of the comments here too, such as, my dad got discharged from the hospital with 21 meds, and there was no way he could figure out when and how to take them, each one written a different way. Or I took one tablet and then 2 hours later, I took another tablet. So these are just some of the issues that we are aiming to prevent. Next slide, please. We also conducted focus groups with community members, and in these focus groups, people designed their own medication label. And something that was found relating to medication directions is that people like to have the indication for use for common chronic conditions on the label, and they preferred more explicit directions over once daily or twice daily directions. Next slide, please. So the Universal Medication Schedule for UMS has been proposed as a way to write directions for adult medications that are taken regularly so that they are more easily understood. And UMS directions use health literacy best practices, such as using explicit timing, such as morning, noon, evening, and bedtime, and also numerals instead of spelled out numbers. Next slide, please. So studies have shown that UMS directions increase understanding of when to take medication more than any other format. Sometimes times per day frequencies require interpretation, and hourly frequencies such as every 8 hours can also be difficult for patients. They also simplify drug regimens. So sometimes people think they have to take medication all throughout the day or wake up at midnight and take a dose, which is not necessarily the case. And taking medications at specific points during the day makes it easier for patients to remember when to take their medication daily. And it also improves communication about medication directions. And all of these together lead to improved adherence. And there have been studies that show that the use of UMS directions can improve adherence, especially in patients with lower health literacy who are over 65 years old or take multiple medications a day. Next slide, please. So the question is, how do you change regular directions that prescribers have been using for decades to the UMS format so that they are on medication labels? In phase 3 of the initiative, Wisconsin Health Literacy did a pilot study in a clinic where UMS directions were coded into the electronic prescribing system by an informatics pharmacist. So a prescriber could select UMS directions and it didn't require any extra steps or clicks for the prescriber. And what was found was that prescribers in that clinic were willing to use UMS directions when they understood the benefits, and it was made as easy as possible for them. So Epic Systems has now created a UMS SIG feature so that prescribers can prescribe as they normally would, and the system converts standard directions to UMS directions, which are then transmitted to community pharmacies. Next slide, please. So having this technology that automates the change is great. It makes it as easy as possible for prescribers. But of course, having the technology alone is never enough. And people are required to make sure that this change happens and it's done well. We found that most physicians, nurses, and pharmacists are not aware of UMS directions and their benefits for patients. So improving awareness and communicating the purpose of change has been important, and as is leadership support. So patient-centered initiatives are prioritized and barriers can be worked through. And there is some planning that's required for implementation. So there might be certain medications that need to be excluded, and there is some mapping of directions required to make sure that standard directions are mapped to the appropriate morning, noon, evening, and bedtime timings, depending on the properties of the medication. Next slide, please. So this is a relatively small change that can have a large impact on patients and enable them to effectively manage their medication regimens and improve engagement in their care. If you have any questions, please feel free to reach out to me. I have my contact information here. Thank you. Turn it over to Farah again.
Lily, thank you so much for talking about this important opportunity that's available and the work that you've done. The fact that it's something that can be turned on with a little bit of effort, as you said, is such a significant change. And it's so important to learn how to access this and what the benefit is. So thank you for presenting this work today. So now it's my turn to speak with you, not just as a facilitator, but also as a presenter, and to wrap it up as the last speaker today, to speak with you about building patient education into our new health information system at UHN. And I think you're pretty well primed after hearing about Epic from so many people and some of the different needs that go into building the system. So it'll hopefully the story of how we're going live very soon will be interesting as well. So the University Health Network is located in Toronto, Canada, and we're one of Canada's largest hospital systems with 4 hospitals and the Michener Institute of Education. And you see you're seeing correctly. Our Epic go live is June 4th. So it's in less than a month. It's a very busy time at the hospital right now, as you might imagine, especially because we're moving over from a number of different systems that have supported information and care. And we're moving all of them, some of them paper-based, some of them electronic, over to Epic on June 4th. So it's a busy time. And so we've got a lot to do, and we've got a lot to learn after our go live date. At the University Health Network, our primary value is the needs of the patients come first. And it's very evident that that UHN has invested in this when you look at the patient engagement portfolio, which is where our UHN presenters are speaking from today. So we focus on patient engagement in care or with personal health care and health decisions, as well as patient engagement in program and service design or at the organizational level. So engaging with patients in their care is something very familiar to people who work in health literacy. That's what we do all the time. And the programs that support this at the University Health Network are the patient portal. So many of you are familiar with portals. Ours is a secure website that allows patient access to lab results, appointment information, and to set appointment reminders. And they're moving over to Epic. So we'll talk a little bit more about them in a minute. Patient learning and experience centers or libraries, which are open for support for both inpatients and outpatients at the UHN hospitals. Patient education and engagement, which is the program that I come from. We build tools and work with providers to build their capacity to engage with patients in care. And then interpretation and translation services, who provide language services at the point of care. Engaging with patients in organizational improvement, you've heard about from Alicia and Lilac and the Patient Partnerships Program, how patients are engaged in making the decisions that affect them most of all. And then finally, patient relations, who help with patient concerns and explore any serious safety events or other needs at the hospital. So our epic journey is one that is really reflective of all of the people, all of the programs that you've seen. So I'm presenting today on behalf of all of these groups and individuals across the programs who have really come together to do this work. So it's really it takes a village. So one of the things we're really excited about, we heard a little bit about this from the Johns Hopkins folks, is the education tab. So this is a new one-stop shop for all of the UHM team members to see the education that's been provided to patients and families. There have been some standard education forms in the organization, but this represents a lot of change for us. So through the tab, providers have access to the learning needs assessments for patients and co-learners, as well as the education tab to assign documents from our custom collection of brochures, as well as document patient education. The other thing that will be available from this tab is a library referral, where providers will be able to refer patients and families directly to the libraries, and the libraries will be able to follow up directly within the system with them as well. And so this is really exciting because having an interprofessional space for education really builds in that team approach, and people are really excited about it. It's a big selling feature for us to be able to tell them that the entire team will be able to see what they've done. And so we're really excited with Epic that we're starting with infrastructure already built in to support education. But of course, there are always opportunities to do a little bit better and to build more in. So I'd like to share with you a couple of examples of how we've done this further. So one is in the learning needs assessment, which has been mentioned, there's a readiness to learn among other fields. And so we looked at the language that staff could select or the fields that were available, and they were eager, acceptance, non-acceptance, and refuses. So intuitively at the start, we were very concerned with non-acceptance and refuses because frankly, they're somewhat stigmatizing or potentially labeling of patients and can convey things that could influence how a patient is perceived and seen by the team. And as well, there's not much of a distinction between non-acceptance and refuses that was obvious to us just looking at it. We wanted it to be very clear and very objective how a patient's readiness to learn would be assessed. So we rapidly reached out to and had a chance to consult, and our professional practice colleagues actually suggested using Prochaska's stages of change for learning, and it worked out really well. If you look at the revised version, it really does reflect a much more discernible scale for learning readiness. And if you look at the bottom, considering we're preparing to learn and not ready to learn, the language is much less stigmatizing to reflect the fact that in healthcare, a lot of people aren't ready to learn, and there can be a lot of barriers versus the notion of refusal. Similarly, there were opportunities to build health literacy interventions specifically as well into the documentation field, which is also available through the education tab. So here you see the original, which was okay, and we were glad it was there, but there was an opportunity to strengthen the health literacy initiatives. So by building in the language of using teachback for verbalizes and demonstrates understanding, we're really leading staff to and reminding them that this is an intervention to use. As well, portal, a small change, but one that we hope will make a difference, is to add prompts to some of these. So needs reinforcement of, and then a prompt to the team to add comments will really help to ensure that the information is passed from team member to team member. And as well, even just within one team member from one day to the next, so that there's more detail and opportunity within the learning field. And then finally, limited evidence of learning, again, is much less shaming and judgmental of a patient's learning. So these were important opportunities to build in health literacy interventions and person first language, which, whether you're working with Epic or another health information system, or even with paper documentation, all of these things can be built in to consider how it is that we're prompting the team and labeling patients, or potentially. So next, I'd like to chat with you a bit about the UHN patient portal. My UHN has been around since 2015, when it started as a pilot, and it rolled out across the organization in 2017. To date, it's grown to 260,600 users, and it was instrumental to us during COVID to help address gaps in communication that resulted from having access to the hospital lessened, and all sorts of opportunities that came out through COVID. With Epic, the team has had to work in two major areas. So one is making sure that the transition for patients is seamless. And the other thing is making sure that the portal doesn't lose any features. So for example, two of the features which are really popular in the portal, they give real-time access to data, and they also give access to the Ontario lab information system. So lab results from any lab across the province. So the team has really had to advocate and together with patients to ensure that the features that are so valued now aren't lost in the new portal. There's also been really great research at UHN on how a health literate patient portal can really help improve care and engage patients. And I'll just share a little bit of that with you too. So 94% of patients want results as quickly as possible. And so by delivering real-time results, we're meeting that need and putting their needs first. And we can also see that the teams, while there can be some trepidation around that, are also supportive and understand the value of that. The portal also really promotes patient engagement, with a vast majority of patients feeling better prepared for their appointments and better prepared to make decisions about their care. And that number at the bottom there, that 11% that hopefully you can see, nearly 11% of people found out of date or incorrect information in their charts, which they were then able to correct. And if you think about the impact on their care, it's significant, or safety, it's really significant. So right there is so important from a health literacy perspective to help people identify potential misinformation in their care. And then finally, so many of our staff, the vast majority of staff and patients, reported that it enhanced the experience through better communication and as well as improved management of care. So the portal is a really important place to build health literacy skills and help people engage in their care. But we know that the portal is as good as the content that's in it. And so that comes back to patient education. So while the portal team is busy working on the portal, we're also making sure that the information in it is clear. So one opportunity that we had was to gather all the appointment prep instructions, which previously had been in the old health information systems, and they weren't standardized and we weren't able to change them before. So when we had this opportunity, we tried to get the information together so that we could standardize it. And we were successful. We got 2,200 prep instructions sent to us. And this won't surprise a lot of you to hear that in the end, there were really only 300 unique instructions out of all of those, because there were small word differences and small changes that for us seem the same, but for patients could be really confusing. And the benefit now is that these instructions will not only go into the patient's portal, but they'll also be included in patient letters that are printed out and mailed to patients without the portal. And they'll also be translated into other languages. So we're really excited to start with a few languages and continue to build that out to increase the opportunity of patients to read in the languages that they're most proficient in. In addition to just the sheer number that we dealt with, I also wanted to show you this example. So you can see on the left here, it's just a straight block of text. It really doesn't emphasize a lot. And we would find that we would hear a lot about people being there at the wrong time, the wrong clinic. The opportunity to revise 11 standard patient letters and then small blocks of text in other areas will really be significant, because it will make sure that the information people receive through the portal and in the mail is much closer to what they see on the right, much clearer, and really emphasizes the most important parts of care. So before I wrap up, I'd just like to outline a few patient supports because we've heard a lot today about how we can develop the best technology, but if we don't help support access to it, we'll be leaving people behind. So very briefly, just a little bit about what we're doing there. So one thing is we know that as we go live with Epic next month, it will lead to disruptions in care. It's inevitable as we learn to use a new system that there will be an impact for staff and for patients and families. So we're developing a toolkit on communication with patients and families to help staff feel more confident answering questions, navigating situations, and to proactively prepare for waits and challenges, and including things like letters to patients that recommend, considering things like extra transit, extra parking costs, time away from school or work, in addition to other things. And so by really helping staff feel comfortable, we hope that it will be a much better experience for patients and that they'll also be excited because we're really excited about this change and patients are when we speak with them about it. So we're trying to really pull all of this together into communications. And finally, our libraries, our patient and family libraries, have long worked with patients to help them access technology and build their skills. And so they've really been focusing throughout the pandemic on the digital skills that people need to access healthcare, and then more recently, specifically on tools they need to access the new portal, including downloading reports as part of the migration. And the libraries is a really important part of our plan moving forward so that when we have the new portal in the hospital, they're able to support patients, answer questions, and help them find the information that they need to get to know the portal well. And they also work with community resources so that if someone needs more support, they're able to refer them to community libraries and other resources to help them build their digital skills. So that wraps up my presentation as well as our formal presentations for the day. So what we're going to do now is we're going to pull down the slides and invite all the speakers to turn their cameras on. And Diana Gonzalez from IHA is going to join us and help by moderating questions for us. So thank you. Over to you, Diana, for the quick Q&A.
Yes, thank you everybody for all those presentations. And I think I just love how, what I just keep thinking of is a humanistic approach. We're moving a lot to technology and still incorporating those principles that I think really connect people and really get them to do the actions and maintain their health. And that's the most important thing, right? So thank you all for all your work. And so some questions that come in, and I tried to keep these straight best I could, to thank you all for participants who wrote in who specifically you were wanted this question for. But I have one from Melanie, who's is the one with the most points here. How did you get your nurses to adopt using the tablet? The organization I work for has been adapting to roll my chart bedside out, but are having poor adoption rates.
So that's a great question. We definitely have some struggles. We get our numbers up and then they go down, but really what we try to do is hardwire it. We have giving the tablet, we made it more of a step in the admission process, not offering, but telling them this is the tablet that'll help you. If you offer, sometimes patients will say no thank you or something. So we have it built into our nurse navigator as just a step that's done in the admission process, but it's a constant thing that we keep an eye on and try to encourage when it's not used.
Great. I think this one's for you, Bomi. Medicine labels often do not state why the patient is taking the medicine. Are there efforts to consistently add the condition to the medicine, the condition the medicine is used for?
Yeah, that is something that we advocate for when we talk to prescribers and health systems as something that patients really need and want. And I know that some electronic prescribing systems do have that option available to always put the indication there. So that is something that we address in our work too.
Great. And I think you folks from Johns Hopkins have filled in some of the questions already, so so you guys can all read those there. Ricardo did ask if you would be able to share your pre and post assessment, and you said you were going to look into getting approval for it. If you do get them and you do get approval, can you also send it to us and we can post it on the website so everybody can have access?
Absolutely. Yep.
Wonderful. Wonderful. Another question is, do UMS directions come in languages other than English? Does anybody know?
Yeah, they have been tested in, I believe, 5 different languages and translated. Um, as far as the Epic feature goes, that is something that I believe is still being worked on, just because it's important to get the English conversion right before moving on to different languages. So the translation has happened into the different languages, but as far as putting it in the electronic prescribing system, that's going to have to be the next step.
Wonderful. And I think these questions are for you too. How did you recruit individuals for your focus group? And were they compensated?
Yes, they were compensated. They were treated as community partners, where we were really learning from them. They were recruited through community contacts that Wisconsin Health Literacy had, and then those contacts would involve connections that they had, people who took medications or were helping other people manage their medications. So it was through our direct contacts and then facilitated through them.
Great. This question's for you, Farah. What sort of analytics do you plan on tracking with this functionality within Epic?
We can't wait. It's a great question, and we're really excited to have the opportunity to look at things like how often patient education is assigned in our custom collection and what types of patient education is assigned. We'll be able to pull out information on how often documentation is done, how often needs assessments are done, and whether teachback is being used. And down the road, we're also really excited to look where we have a big focus on what we call PREMs and PROMs, so patient related outcome measures and patient related experience measures. So when we're a little bit more mature in understanding the data that we have, we're also really excited to link some of these things to patient related measures to see what types of outcome differences they make. So it really feels like having a system like this allows us to pull information that we never had access to before.
Awesome. I think this one might be our last question. How are you able to evaluate the uptake of patient education tools in Epic? And
That's a great question.
Oh, go ahead.
I was going to say, if we want to start with the folks from Johns Hopkins, maybe because it sounds like you're the most along the journey would be great.
So we have a couple of different ways that we evaluate it. So we can run reports to see how often our teaching plans are used, which are the titles that are built in Epic. And we can also, within bedside, we can see how much the patients, like the percentage of the time that the patients are in the to learn module, where they'd be watching the videos or looking at handouts. We also, our third-party vendor for our patient handouts and our videos, we can get reports from them to see our usage. So it's multiple ways.
Bumi, are there any evaluation measures built in to the medication instructions?
Can you clarify on evaluation measures?
Sorry, yeah, I guess any recommendations of how organizations might look at how the instructions are being used, or whether there are opt-in or out options, or is it just really a turn on and then away it goes kind of a thing?
Yes. Basically, you would turn it on and implement it. As far as measuring impact, that could be done by each organization, measuring if there is a change in adherence or a change in how patients understand their medication information.
Another question we have for you is follow up on the medication info. Will the process of displaying the condition on the medication label still be HIPAA compliant, and also avoid stigmatizing patients with certain conditions?
I think that's asking about putting an indication on the prescription label. Um, and so sensitive information should always be left off. I think an indication is most helpful for chronic diseases, and that's something we talk about when we meet with prescribers and health systems. As far as HIPAA compliance goes, it would be compliant to have it on there.
All right, I think we have time for one more question, and it's how do you get your patients to be more interactive with the system?
Is that for the tablet or?
I think it's for everybody. I think if we're all trying to get people to interact with it, how's the uptake look? So if anybody has any thoughts about that, we'd love to.
I could say one thing that we're doing at Johns Hopkins is we are implementing food ordering. So one of our hospitals have gone live with food ordering on the tablet. So that's a win for nursing because they don't have to help them as much with calling or getting orders in. And then it's also a win because it gets the tablet in the patient's hands, so it gets them more engaged in their care. But that was something, food is always a motivator, I think.
Absolutely.
For us, I think we can speak to the portal in general. And I mean, certainly the pandemic has been a big factor in getting patients engaged and on board. We used to go out and have, sort of recruitment pushes where we would try to get the numbers up. And then through the pandemic, the numbers just they exploded because people really needed to access the system. In addition to that, we found that really patient voices are often the best ones to promote the portal and the reason to sign up for the portal or engage with it. And that's for both patients and for staff. So often when we have opportunities, we'll work with patient partners and really ensure that we've set it from their point of view. So whether through videos that promote the features or quotes in different resources, if they're written, we try to use the words of patient partners to convince people why they would want to get engaged. And we've found that by having a system that's designed with health literacy in mind and is really clear, because it's intuitive, people tend to they know how to use it, and they start to use it once they're logged in. That's often the biggest barrier. If our portal team was here, I'm sure that they'd have a lot more to say as well. So hopefully I've represented that all right for them.
Wonderful. I think we're just about at that time. And so I wanted to thank all of you guys for your time, for showing up today, and for the amazing information that you've provided today. After the session, we have our closing session. So it's just a short 15 minutes, and we'll just wrap it up with everybody to just to hear your main thoughts. We'll review that virtual idea board and throw in any last thoughts you have in that discussion session. So thank you all. And Farah, did you want to wrap up with any questions?
Thank you. Thank you, Diana. And thank you, everybody. I just echo thanks, and really just thanks for everyone who attended today. I know that we focused a lot on Epic and on larger health information systems. I hope that you were able to pull out practices and information that can help you, whether you're on Epic, whether you're on another system, or if you don't have a full health information system, that there are pieces that you were able to take away from today. And please do reach out to speakers on the panel who've shared their contact information, so that it was just a bit of information we are able to share today. So stay in touch, and hopefully we'll continue to learn from each other. Thank you, everyone, so much for joining us today.